All right, let's talk a little bit about assessing chest pain and the different types of chest pain. So, the first one we're going to talk about are your common cardiac symptoms. Okay, those are usually called or described as a pressure or squeezing. Okay, I've heard people say, feel like an elephant sitting on my chest, feel like a ton of bricks sitting on my chest, it feel like somebody's sitting on my chest. Those are all pressure type pains. I feel like a rubber band wrapped around my chest. That's the squeezing that they're running into. So pressure, anything that describes pressure is a very significant and indicative of cardiac in nature. They may have shortness of breath. Okay. Shortness of breath generally comes from the fact that they're having that pressure on their chest, but it could also be from the heart lacking oxygen. So they have to breathe faster to try and get oxygen to their heart. So shortness of breath, they can complain of shortness of breath. They can have nausea. Pain can radiate. And the radiation is typically into the jaw, also to the arm. The left arm is most common, but that doesn't necessarily mean that's the only one. This one can come on with exercise or at rest. Okay, so generally described as a pressure, squeezing, shortness of breath. There's nauseated related with that. The pain can radiate. It can go into the shoulder, up into the jaw. It generally comes on with, it can come on with exercise, also can come on with rest. This is the one that when it comes on at rest, any chest pain that they have that comes on all of a sudden, they're just resting or it woke them up from sleep, definitely very indicative of cardiac. So you want to put all those things together when you start looking at the types of chest pain. So then let's move over to a pleuritic chest pain. Pleuritic meaning generally of the chest or chest wall. So these are usually described as sharp, dull, ache, burning. It increases with breathing. Okay, sharp, dull, achy, burning. It increases with breathing. It can be reproduced. Can be reproduced either by palpation, or breathing, or something else that may cause, it could be movement. Okay, so it is reproduced. Over here with cardiac, it is not reproducible. Okay, that is an indicator that it's cardiac in nature. So if they say they're having shortness of breath, the chest is tight, it hurts. When you press on the chest, it's not going to reproduce the pain. It's not going to make the pain better or worse. So there are a lot of times no aggravating or alleviating factors. So that is definitely something to take into consideration. Now, with the pleuritic chest pain, kind of the same thing. It can decrease with rest and stops with rest. So those are generally your pleuritic type chest pains. Musculoskeletal is very similar to pleuritic. The primary difference with musculoskeletal, we're going to do the same thing. This can be sharp, dull, ache. Let's see, burning could be. And this can, more importantly, increases with, and I should say, specific movement. Such as their arms, so musculoskeletal chest pain generally brought on by some type of move, or it can increase with movement, and whether it's moving your arms or again palpation, it is reproducible. So you can reproduce it, or the patient themselves can reproduce it by doing certain things. So when we say, is there anything you can do that makes it better or worse, or that makes it the same, or that you can reproduces it, then that's what we're looking for is it reproducible? And again, cardiac is not generally reproducible, whereas musculoskeletal pain is reproducible. So we've already talked about the cardiac and the difference between a myocardial infarction, or MI, and angina or angina. The primary difference between those is that angina goes away with rest, generally within 10, 15, up to 30 minutes. Once they rest, nitroglycerin, it goes away. So that would be angina or angina. The cardiac type heart attack, MI, myocardial infarction, that does not go away with rest. The other thing with cardiac that is an MI is when it comes on with exercise. Consider angina if it comes on with exercise. Other than that, it's hard to tell the difference between a myocardial infarction and an MI. So it's still cardiac related. We still treat it like it's a heart attack. We always treat for the worst, hope for the best. That's what I always tell the patients. Treating for the worst and treating like you're having a heart attack. If that's the case, worst case scenario, I'm going to give you a headache and, we'll take up some time at the hospital. But best case scenario is, we get in and out, or I think I said worst case scenario. Worst case scenario, there's definitely something going on and we're ahead of it. And best case scenario, I give you a headache and you are able to get discharged shortly after. So that's the primary difference between musculoskeletal and pleuritic pain and cardiac pain. Pleuritic pain it can have nausea. Depends on how the person's pain tolerance is. You can have the same thing over here. So you can run into that. They may have shortness of breath. And that may be generally due to sometimes guarding. And what I call guarding is when it hurts, they don't want to take a deep breath. So the guarding can cause them to not get enough oxygen if they need to. So, or as they need. So that could be part of the issue. And the same thing here. They can be short of breath. So between the musculoskeletal, pleuritic, and cardiac, you see a lot of the same things, but the primary ones that we run into that scream cardiac is it's a pressure, it is radiating, generally into the jaw, arm, something like that, comes on with rest specifically. It is not reproducible, and there's generally no aggravating or alleviating factors, not really anything they can do to make themselves to make it better or worse. A couple other things to consider is indigestion. That is a common complaint that patients with cardiac events will have. They will say that it feels like indigestion. They'll take Tums or antacids or something that for an extended period of time. Sometimes the worst I've ever seen was I think 3 days before he finally called EMS, and unfortunately he didn't make it to the hospital before he went into cardiac arrest. Luckily we were able to get him back and get him to a cath lab where they were able to do whatever corrections that they could. The musculoskeletal pains generally brought on. One of the other things to keep in mind is there's a lot of times some type of previous exercise may run into that with pleuritic type chest pains as well. So that exercise could be reaching, could have been moving, they could have been actually doing something out in the yard, something along those lines. That generally is indicative of a musculoskeletal pain. So the signs and symptoms that we generally look for that are cardiac related are going to be that pressure, squeezing, tightness in the chest. Sometimes I've heard them describe as a heaviness in their arm, heaviness in their chest. Anything along those lines are very red flags, very big red flags for cardiac events. Those generally will radiate up into the jaw, down into the arm. The left arm is the most common. It can go into the right arm as well. And any of these things that come on when the patient was at rest, while they were asleep, or not really doing anything, and it just started all of a sudden, that screams red flag, potential cardiac event. So it can be brought on by exercise, but that can lead to angina or angina. The primary thing that we're looking for, though, are those pressure, squeezing, tightness, heaviness. Your musculoskeletal pain and pleuritic pain, both of which have the sharp, dull, ache, burning type pain, they run into those. Those pains can be reproduced with palpation, deep inspiration, movement, anything like that will reproduce the pain, and it's the same pain. That leads you more towards a pleuritic or musculoskeletal pain versus a pain that you cannot reproduce it. You can't make the same pain. You can't make it better or worse. That is more cardiac related. One thing to think about with cardiac is diabetics. Diabetes, just the disease process itself, it is not uncommon for them to have abnormal presentations of cardiac events. So these are the ones that you hear the horror stories of. My big toe was hurting and it ended up being a cardiac event or a heart attack. Those are few and far between. They're rare, but keep in mind that a diabetic can present with other signs and symptoms outside of your traditional signs and symptoms. It's common for females to present with signs and symptoms that are outside of the normal. But again, for the most part, this is your overall cardiac type chest pains. these are your pleuritic or musculoskeletal type chest pains, and that's how you kind of differentiate between the two. Good rule of thumb, anything from the waistline or belly button up, specifically the belly button up, any type of pain in that area, we consider some type of cardiac event. Let's do a full assessment, 12 leads, send those 12 leads off to the hospital, have them evaluated or have them ready for the ALS providers when they arrive. And that's the types of chest pain, differences between them, and how to basically tell, is it pleuritic, is it musculoskeletal, or is this a cardiac type chest pain?